Welcome to the last Think Global of the 2025-2026 season. I'm delighted to be back here at this podium. My name is Kearsley Stewart. I'm faculty here at DGHI, although I haven't been in the classroom in a couple of years because I've been focusing on the project that we're about to present to you. So welcome to everyone here in the room, and welcome to all of our collaborators and colleagues online. Good morning, good afternoon, good evening. We're delighted to have a lot of folks from Uganda online, so that's very exciting for us. So let me, first of all, I want to congratulate the team who was just at CUGH last week, and some of you may have been with them. We had a very large membership from our team there at CUGH. We presented 3 posters, so we were really excited about that experience. Almost everyone who's in the picture is here today to present. So congratulations to the team. What I want to do in a few minutes, I just have sort of 3 or 4 minutes to kick us off, and then we have a very packed agenda. We have an opportunity for almost all members of our team to present in sort of 5-minute segments. What I want to do is tell the story behind this slide. So this slide represents 8 years of collaboration. It represents the last sort of 5 years of very intense interaction between the team in Uganda and here at DGHI and also at UNC. What I want you to take away from this slide is that we are an interprofessional team, and we really pride ourselves in the fact that we have many disciplines and fields actively involved with this project. So how did we get to where we are today, to have so many students, faculty, and clinicians in Uganda and here in the United States collaborating on sickle cell? Well, it's a decades-long collaboration between myself and the director of the sickle cell clinic in Uganda. His name is Musau Mbabake. And it goes back to my PhD research when he was a high school student, and he joined my team as a research assistant. And we're talking 30 years ago, guys. He and I have stayed together for those 3 decades, and in that interim, he's become a professional clinician. And when he was working for the government of Uganda, and about 8 years ago, he was transferred to, you can't really see it here, but the islands in the middle of Lake Victoria off of the Uganda coast, and to work in a very remote setting. He immediately recognized an unmet need for sickle cell. And so there was no sickle cell therapy. So Musau Joel started a clinic and invited me a few years later to collaborate with him, bring in Duke, bring in UNC, bring students. And so one of our sort of principles is that we're using research to advance and to improve patient outcomes. So that's one of our principles. The other thing I want you to be aware of, you might not be aware of, is that there's a very serious health equity issue with sickle cell. So only 1 in 5 children, so that's 80% mortality for children by the age of 5. Okay. That's a huge health equity issue. But Joel and I reasoned that if Uganda was so successful with bringing down HIV prevalence from 30% in the 90s to less than 1% today, why can't we do that with sickle cell? So that's the mission that we set ourselves on, and we've been working on that together. One of our really dates that we're very proud of is 2022. Since 2022, we've offered free hydroxyurea to all of the patients at Joel's clinic. It's expensive, it's difficult to get, but we've been able to do that. So that's one of our proudest achievements. We achieve all of this through a pretty classic sort of framework of research, improving infrastructure in the clinic and the lab, training. One of our principles is that we train. When we bring a UNC or a DGHI student to Uganda, we twin them with a Ugandan student as well. So building up skills there. We have a deep rooted presence in the community. And we're also working on this issue of health equity, and that's at the policy level. So we're going to hear from Emily Pepper today on a Delphi survey that we've been working on. And a big shout out to Gab and Amy's group, the CAVE team that have been helping us to develop policy briefs and an action plan. Funding. We have had many people support us. Here's a list. We've had a lot of support from DGHI, and we're really grateful for the support from DGHI over the years. Other offices that do, we're really proud that we have a Fulbright member of our team. She got a Fulbright Research Award, and she's there. She's going to be presenting some of her work in a few minutes. And again, the free treatment from private donors from the United States and Uganda. So here's our brief agenda. I'm saying that with a little bit of humor there. We have a lot to do. So why don't I just jump right in? And we're going to move to our first speaker, who's online, Dr. Deo Gracias Manube. And I want to start with a huge thanks to Dr. Manube, Dr. Deo, who has been a mentor since the beginning of this project. He has mentored me and Musao Joel. He's really guided everything we've done, and we couldn't do what we do without him. He is one of the leading members of the largest sickle cell clinic in Uganda at Mulago National Referral Hospital. He's a pediatrician oncologist. He's on faculty at McCurry. And so we're really, really grateful to have Dr. Deo with us to kick us off. So Dr. Deo, it's up to you.
Thank you, Carrie, for the kind introduction. And I would also like to thank the whole of the Duke team for all the work that is being done. I've been introduced, so let's move to the next slide. So that's also my brief outline, which I'll take us through. Next slide, please. So we're all aware that sickle cell disease has a high burden within sub-Saharan Africa. And this heat map you can see on the right shows you the proportions of sickle cell disease, and more importantly, the proportions of sickle cell gene within the African population. And you will note that most of these sickle cell gene patients, or should I say, people who live in Africa, tend to be within an area where malaria is quite high. And we do know that the presence of the sickle cell gene has a clear protection, and it reduces the severity of malaria in the population. And it has allowed the gene to move from generations to generations. Carrie had mentioned clearly the high mortality that is associated with sickle cell disease in the African population. If we're unable to diagnose early, if we're unable to begin evidence-based treatment, you find that these mortalities are quite high. And we will see in several of the discussions how these mortality can be reduced by introducing simple things such as early screening and interventions. Next slide, please. Uganda, as our case study in this case, we are fortunate to have gone through significant studies that have looked at the incidence of sickle cell disease and also the incidence of the sickle cell gene in the Ugandan population. On the right side, you'll see a heat map where the darker colors show where sickle cell gene is. And in some of the areas, you find the percentages as high as 25%, with an average of 13% in the whole country. Kalangala can be seen just in the lower part of Lake Victoria. You need to focus a little bit more, but it's also quite colored. So it tells you that there is presence of sickle cell gene and the sickle cell disease. We have some interventions which are done based on this study, which looks at the high burden in both the eastern and the northern parts of the map, as you can see. Next slide, please. So what are some of the system challenges that we do see? It has been highlighted that late diagnosis can lead to increased morbidity and mortality. Limited access to evidence-based interventions such as hydroxyurea can also reduce the number of cases that we see with regards to diseases, complications, and sometimes even mortality associated with sickle cell disease. In Uganda, over the last 60 years, we have had generally a centralized care. I work at the National Referral Hospital. We've had a clinic which has been there from the early 60s. And we, over the last 10 years, have tried to ensure that we decentralize the care. And we do know that as we improve the decentralization, we can see less complications and fewer mortalities. Next slide, please. Uganda as a country has taken a positive role to improve the outcomes of sickle cell disease. There's early diagnosis, which is now being introduced, as I'll share later on. There's improved access to treatment. There's a deliberate effort to decentralize the centers of care, and more importantly, to focus on areas where health equity has a major focus that we need to look at. Next slide, please. This year, just a few weeks ago, the Ministry of Health rolled out what we call the mandatory newborn screening for the country, which is a big landmark, which would help us to diagnose the children with sickle cell disease and also enable us to know those children who are born with the gene so that they can be long-term interventions. More importantly, we shall be able to develop a registry, and this registry would allow us to keep following up the children who have sickle cell disease. And we know early interventions can reduce mortality. Early interventions can help reduce most of the complications that we are seeing. Next slide, please. We have an ambitious strategy to increase the access of hydroxyurea to all people with sickle cell disease by 2030 years from now. And this really has been taken on by the inclusion of hydroxyurea in the essential medicine list. And this allows the government to put in more resources. And this is something that we are pushing for. And we know with such an intervention, the benefits of hydroxyurea, such as the painful crisis, the recurrent chest infections, strokes which occur, can improve the outcomes of people living with sickle cell disease, and more importantly, improve their survival. There will be some challenges associated with this, ensuring that the supply chain is sufficient to have the drugs available. And more importantly, we have also learned that having hydroxyurea does not ensure that everyone takes it. So we need to look at key aspects of our adherence to ensure that hydroxyurea is taken. Next slide, please. Decentralization is really the key for us. We need to move our services from the center to the periphery. And Kalangala, as you will see, are one of those success stories. Another success story is the integration of sickle cell disease into the non-communicable diseases and the creation of what we call the chronic care clinics or the chronic care approach, which means we can train, we can educate the healthcare workers, and they can provide care to improve access of people living with sickle cell disease to get care, to reduce the burden associated with traveling from one place to another, and more importantly, the continuity of care across the lifespan. Next slide, please. Health equity has been highlighted. It's really an aspect of can we improve the outcomes of people living with sickle cell disease. And I share here in these slides that we have seen the opportunities of having the pediatric population grow into the adolescent population and grow into the adult population, which enables us to improve access. It enables us to push the treatment and care to certain specific geographic areas where in the past they would never have access to this care. And this enables the health system to grow, and it enables us to strengthen our outcomes. Next slide, please. As I conclude, Uganda has three main aspects that we're transitioning to: the national newborn screening, universal access to evidence-based interventions, and more importantly, the decentralized services. I do believe with these three main aspects, we can use Uganda as a possible model to improve the outcomes of sickle cell disease in sub-Saharan Africa. Thank you all for listening to my presentation. Over to you, Kari.
Thanks, Dr. Muzeke. If you have questions, let's hold them till the end. Our next speaker is both Maddie Kitts and Dr. Stephanie Bemery. Dr. Bemery is in the School of Nursing here. She's a beloved member of our team and of our lead trainers for some projects that we've done going overseas to Uganda and some global training. Maddie, who's going to kick off our this segment, is a former Master's Global Health student who sat in this very room for as many hours as you guys did. And I'm really delighted to say that she was awarded a Fulbright Research grant, and she's going to report on that. Maddie, can you hear us?
Yes, I can.
Okay, there she is. She's in Kalangala, finishing up her Fulbright year. Go ahead, Maddie.
Great. So thank you for the introduction. We can just jump right into the next slide. So Dr. Manue did a great job at talking about the new developments for sickle cell care in Uganda. These they started June 19th and that are developed. However, we're going to be reporting on 3, mostly for time and for relevancy, as not all of these tools have been implemented at Kalangala Health Center IV yet. So the 3 that we're going to be touching on briefly are the revised sickle cell guidelines. So they now reflect regional and international standards. And what that means is Uganda is really focusing on, like Dr. Manube said, the chronic care model, trying to make sure that we have long-term care as well as early intervention for newborn screening. That brings us to our non-communicable disease register. This now includes sickle cell disease, which will be a great way to monitor our patients long-term. And we have the newborn register, which it's in all maternity wards. It's this big red book, and there's now a section to include newborn screening. Next slide, please. So newborn screening, this is what I focused on when I was doing my master's thesis. And at Kalangala Health Center IV, it began in 2024, early February. And newborn screening is now a program that is ongoing, and 55% of screens are done in the maternity ward. And interestingly, 43.9% are done during immunization days. And that's important because only 7.6% of women who deliver in the district deliver with a skilled clinician. So the majority of women are delivering at home or with traditional birth attendants. So that's a large population that we are missing for that 24-hour to 48-hour window that you typically see with newborn screening. So our immunization days are vital for getting infants or newborns that were born in other islands that could not access a health center for delivery. So we see immunizations and newborn screens done up until 2 years. So it's important that when we think about newborn screening, we view it not just for the newly delivered babies, but for all the children that have not been screened yet. So there's a lot of gaps, but when I did my interviews with the midwives, one of the solutions was newborn screening outreaches alongside currently existing immunization outreaches. And I thought that was a great idea. This is a program that has been done at Kalangala Health Center IV in Bwendero, not necessarily with newborn screening, but with immunizations. They go to hard to reach islands. Kalangala is already hard to reach, but there are other smaller islands that don't even have health centers. So they go to these communities and they give out the mandatory or very basic immunizations for young children. And so the idea of doing newborn screening alongside that, I thought was a great idea. And some of the other things that would be needed for health system strengthening is clear leadership on that. And interestingly, some sickle cell awareness during antenatal care. Next slide, please. So another big thing that we are focusing on is quality improvement for clinical care delivery. We have 3 main topics that we're going to discuss very briefly. I'll discuss 2 of them. our data management, we are constantly organizing and cleaning and analyzing our data just to see where there are gaps and where there are really solid data that we can start to analyze further and use it to improve our clinic as well as our research. And then our clinician training, we are really focused on that. We want to make sure that our patient forms are being filled out comprehensively and honestly trying to make the job easier for the clinician as they're already so busy and it's a busy clinic. One of the tools that I'm working on for my Fulbright is the development of an herbal medicine book. The majority of our patients use herbal medicine, but they might not be able to identify exactly what they are taking. So this book is hopefully going to help not only the patient, but also the healthcare worker. And I will pass it off to Dr. Ebemery.
So thank you, Maddie. The other part about training clinicians that is really important is to make sure that they understand sickle cell disease inheritance and how the gene is passed along. One of the things that I found the most interesting about joining this team is having the opportunity to realize some of the work that I've been doing in Nigeria myself and bring it to Uganda. So for example, in 2023, which is not on this slide, I was invited by Professor Stewart to do some genetic counseling training online. The genetic counseling training online went well, and I was asked to now bring myself to Uganda to continue said training. And so I was very, very grateful to have the opportunity to go and do 2 interactive genetic counseling training sessions with clinicians, students that are here today, researchers, and my colleagues there in Uganda who are nurses as well as I am. The topics included, what is sickle cell disease essentially? What is genetics? Because I think we assume that everybody understands what genetics are, and so we brought it all the way back to basics. What are the inheritance patterns for sickle cell disease? And what are the principles of genetic counseling, which are a little bit different than what genetic counseling actually looks like in the field in many African countries, where it's very directive. And the principles of genetic counseling advise us to be non-directive, but informative. So if you can't tell, I'm a fun person. And so one thing we're going to do when we're learning is having fun. And so one of the things that you'll see here in this picture is all the fun that we did have. Learning is the best whenever you can attach it to a fun memory, I think. And so we played games like Find Your Family. I gave everybody, thank you, Pepper, for helping us. We gave everybody little cards to go and seek out their family based on their genetic, their genotype that was listed on the card. There were other games such as the genetic risk in the cup game to help people understand how it is that one family can end up with more than one person with sickle cell disease in their family, which is a very difficult topic in this context. I had the great opportunity of meeting the Musau Joel, which is up in the very top, I think, left-hand side of your screen. And then we have more images here of the incredible work that Maddie Kitts is doing on ground right now with midwives and clinicians. And I, of course, had to get a picture with Dr. Manube. Can't leave Uganda without one.
Thanks. All right, I'm going to welcome up Daniel Lee, who also is a former student, undergraduate in the Duke Global Health major. Daniel is now at UNC pursuing an MD.
Yeah, Tar Heel.
I know both sides, so I'm going to hand over to Dan.
Yeah, so I was an undergraduate, like many of you, but I switched sides. But during my time in summer of 2024, I visited the field with the Maddie Kitts, and my study was titled Barriers to Hydroxyurea Administration, Monitoring and Adherence, and this is a mixed method study. So some context, Dr. Manube described hydroxyurea a little bit, but this was introduced into Ugandan government clinics around 2021, and it's really just a pill in your top right. And it treats sickle cell disease by elevating what's called fetal hemoglobin. I'll refer to it as HbF. And it does so by preventing aggregation of HbS, which is your bad sickle cell hemoglobin. So this is the only disease-modifying drug available in many of these Ugandan government clinics. It has great life-saving potential. It drastically reduces sickle cell disease complications, mainly these vaso-occlusive crises, around 50%. And you also see reduced mortality, but this is always seen with long-term treatment. So good adherence is definitely a must here. And so this study basically had wanted to see the entire perspective of HU, hydroxyurea administration and management in Kalangala Health Center IV. And we did this through a structural, biological, behavioral, and psychosocial lens. And this study had two prongs, one being a clinician-oriented prong. We interviewed 5 clinicians comprised of the entire sickle cell disease department in KHC4, and also through patient interviews. We had 52 patients, and we also interviewed them about theirs, hydroxyurea, their current adherence levels, et cetera, et cetera. We also, what makes this study on the more unique side is we also took some biological measurements, mainly the HbF fetal hemoglobin levels. So some of the barriers we identified in this study, on the clinician side, all clinicians cited equipment and supply chain as being a concern, not only in the actual supply of hydroxyurea, but also of liver and renal function tests. Many of these patients are supposed to be laboratory monitored, but a lot of the times these tests aren't available in KHC4. Training and staffing are also huge barriers, especially with continued medical education. Hydroxyurea treatment is always changing. You saw the new guidelines, and there's a little bit of a knowledge gap there. Finances are also a big barrier. Dr. Stewart mentioned this a little before, but a lot of the hydroxyurea actually has been supplied by gracious donors in North Carolina. On the patient side, many of the patients actually reported no barriers, but some of them reported forgetting, a lack of info and knowledge gap between patients and providers, stressful home environments. This is unfortunate, like interpersonal violence, pushback from parents dissuaded patients from taking their pills, psychological factors like depression, anxiety that comes with adhering to a strict regimen, and of course, pushback from traditional healers that dissuade them from taking hydroxyurea and instead for herbal medications. Some of the associations we saw between barrier frequency and MARS-5, which is our adherence metric. Basically, we saw that the greater the amount of barriers someone experiences, the higher the chance of having a lower adherence limit. Especially amongst patients with greater than 3 barriers, we found around a 4-point drop in adherence with that. We did not find any significant association between fetal hemoglobin and adherence, but we did see a declining trend in fetal hemoglobin, around 10% between patients that reported 3 or more barriers and patients with 0 barriers. But this is not statistically significant, sorry. One statistically significant trend we saw was especially in patients that reported access as a barrier, so access to the clinic, access to hydroxyurea in general. We did see a decline in HbF of around 10%, and many studies cite that 20% mark of HbF. If patients fall below that, they have greater risk of vaso-occlusive crises and other sickle cell disease complications. So the key finding of the study, we found unique barriers to hydroxyurea treatment. This is especially in a non-urban and non-hospital setting, which not a lot of studies investigated yet. And we saw an association between patients experiencing lower adherence and a greater amount of unique barriers. We also saw a declining trend in HbF with greater barrier counts. And we also identified a patient population that is at risk for greater STD complications, especially patients that reported access to the barrier with around 50% mean HbF level. So in terms of next steps, one which has already been done already, so the dissemination of results, KHC4, there needs to be a push for more holistic, personalized care, interpersonal violence, traditional healer influence, and a transition to adulthood. These are all very personal barriers that call for more personal interventions, many of which have already been done in KHC4. Musao Joel often calls patients with lower adherence to come volunteer at the clinic, and they sort of sense of community as they help to treat other SCD patients. There are many social circles. I remember in my time in the field, we had like International Sickle Cell Disease Day celebration. We shared like cake. We talked about our illness narratives. And of course, a strong patient-provider bond is very apparent. I mean, everyone in the island knows who Musao Joel is. They always hit up his phone. Sometimes I have to answer some of them. And although challenging, there needs to be greater interventions for these structural barriers, greater support from the Ministry of Health in supplying hydroxyurea supply, and especially greater support for low-level healthcare facilities. Kalangala Health Center is a level 4 facility, but level 2 and level 3 facilities are often more accessible to some of these patients outside of Uganda Island. There needs to be greater integration with community healthcare workers, especially to close that knowledge gap between patients and providers. And these are just some pictures of the field. So a lot of times I had to visit like these schools, patient homes, and bring around this little device to measure their fetal hemoglobin.
All right. Next up, someone who's well known to everyone in this audience, Julius Mushangi. It's been my great pleasure to work with him for the last 2 years as he completed and successfully defended his master thesis. Julius.
Okay. All right. It's great to see people here for sickle cell. That's a great thing. Yeah, so I'll talk about the work we've been doing for the last 2 years in 5 minutes. Quite a good challenge, and really calling on from what Daniel was talking about, hydroxyurea. So a great innovation, was first approved by the FDA in 1998. So that's about 24 years before it first got to Kalangala. So 2 decades before this life-altering medication could actually get to the ground and actually affect the patient's outcomes. Now, when you're thinking about sickle cell, think about pain as one of the main outcomes that patients are experiencing, and think about how such a medication would actually alter those outcomes. So what we did, we wanted to understand this idea that how can we optimize hydroxyurea? How can hydroxyurea be optimized in low resource communities? One unique thing that we need to mention here is that Kalangala is an island which is an archipelago. In an archipelago of 84 islands, 65 of them that are habitable. So patients have to travel significantly to come and get care. So even as we talk about decentralization, we're not just talking about decentralization from the national level, we're also talking about decentralization from one island to many remote islands, which we had an opportunity to actually go and experience myself. So what we did, we went on and undertook quite an ambitious project by collecting a lot of data. And I want to thank students from UNC, students from Duke undergraduate, who are some of them right here seated in the audience, and then also friends like Alan in the class who were helping me go through this data. And what we did, we collected 87 surveys. We did a lot of medical records instruction. Medical records are contained in patient books. And so you had to go in and read the handwriting and try and translate that to databases. And then also in-depth interviews, which we did 45 with 3 unique groups, which was patients, caregivers, healthcare workers, and stakeholders. What we were doing through our the data analysis, as we identified factors that were relevant, we were placing them in this socio-ecological model that would allow us to account for those factors in one level to the other. One thing that we were not able to do, and it's a very interesting thing that we're thinking about, is look at how do these factors interconnect or interrelate from one level to the other, because as Daniel mentioned, patients who are experiencing unique barriers or unique factors were also experiencing more outcomes, negative outcomes. So we were also trying to see how those interactions were there. We weren't really able to account for that, but there was 2 unique findings that we found, which I'll be presenting to us today. And this one was the idea of dietary diversity and the recurrence of vaso-occlusive crisis. We did, through our subjective survey, we were able to account for protein intake, weekly intake from a patient report. And what we found was that patients who had low to moderate protein intake were presenting with recurrent vaso-occlusive crisis at a higher rate. And so coming from that, we collected some objective data from serum albumin, which could account for low protein within the body. However, it does have many confounders. Sickle cell disease in itself as a condition could contribute to that. But what we saw was that patients who were experiencing lower tiers of the serum albumin levels were also experiencing lower levels of fetal hemoglobin, which could maybe point us to a direction to say that patients who are having low to moderate protein intake were experiencing a higher recurrence of vaso-occlusive crisis. When we ran an adjusted Poisson model, we found a prevalence ratio of about 4.74. So about five times more recurrency among them than the ones who had a high dietary source. And so that was quite interesting to us. We think it's a great opportunity for us to go ahead and consider longitudinal studies, including pain diaries that could help us really understand how vaso-occlusive crisis is playing out in this population. Another very interesting finding that we found was that the frequency of clinic visits also are giving us a picture when it comes to these outcomes. Specifically, when we were looking at the data, we found that we had a lot of missing data. And when we call it missing, it's the actual word was that it was actually not taken. Because the clinic depends on government resources. And so when it comes to fetal hemoglobin, liver function, and kidney function, the reagents replenishment requires the government health system chain. And so when it's limited or when it's interrupted, patients could actually travel to the clinic and not get this crucial evaluation that can actually help in escalating hydroxyurea. So the challenge here becomes dose escalation of hydroxyurea is not really happening as appropriately, not because the clinicians don't want to do it, but because they don't have the capacity to longitudinally monitor. And so one of the conversations we are having with Dr. Monube and other clinicians is this idea of how can we bring this optimization through customized guidelines. So if we're not able to evaluate liver and kidney functions, what are the simple, very basic observational strategies that can be used? For example, evaluation of jaundice, or looking at liver hepatomegaly, or even just patient reports. As Daniel said, Musaljo has a phone for all the patients and a great team there. So they are able, maybe through an mHealth strategy, to be able to report any outcomes that they get. And through that, they're able to see if dose escalation is actually appropriate. And then we also are recommending this idea of integrating nutrition within sickle cell disease care. So being able to evaluate through more rigorous strategies like a 24-hour recall of the diets that they are having, but we also try to discuss with nutritional epidemiologists that could help us understand how better to evaluate this. So thankful for the team that has continued to participate in this. Passing on to Emily.
Thanks. Ms. Julius, our next speaker is from UNC. Emily Pepper has been involved in a Delphi survey. This is related to our work to create data for policy. It's a policy brief. So Emily.
Right. Thank you so much for the introduction. Wanted to make sure I hit the right button. But to get everyone started, we've heard so much in our presentation today. We've talked about genetic counseling, and then we've talked about just the factors that influence patient outcomes. But something I do want to discuss today is on policy. So while also to note, Dr. Manube made a comment about a lot of the points that I do have on this slide, but currently, as of now, these are still true, but they are working to the more positive side. So with a lot of the information you see, we started this Delphi survey last year. I believe it was March 2025, and it only just finished now, March 2026. So a lot of the stuff we were going over was stuff that has yet to be impacted. So in February 2026, the Ugandan government had stated that they were going to begin their national newborn screening program, which is amazing. That is exactly what we want to hear. So when you see some of these responses, please keep in mind that some of these items that have recently occurred were not yet out. And so that is going to be the reason why some of these are a little bit different or changed versus what you might have heard previous presenters state. But as of now, the problem still lies that Uganda has one of the highest burdens of sickle cell disease globally, and yet as of now, or at least 2025 when this data was taken, only 20% of newborns are actually screened, and they are primarily in urban areas. There is still little to no consensus on really what are the barriers that are causing the most problems of people who live in Uganda with sickle cell. And we don't really have consensus on what strategies would best be implemented to reduce these burdens. So that is why we chose the Delphi survey, because the Delphi method is a complex, structured, multi-round survey that helps bring expert consensus together and essentially allow us to align all of these opinions. And we have used that to ask the question, which barriers are hurting the people the most, and what strategies can we realistically and feasibly implement. So before I get into the findings of our Delphi survey, I did want to say who shaped this data. So we had 108 unique respondents that had joined our survey, but 54 of them had joined for round 3, and round 3 is when final consensus was identified. So a majority of participants were Ugandan-based healthcare providers. They were researchers, they were NGO staff, and they were advocates. And the priorities that they chose deeply reflect their lived experience and their frontline practice. So we want to look, how does the Delphi survey work? What is the methodology? Well, first, in round 1, we bring in people who are eager to participate, and we ask them open-ended questions. We were asking about the barriers that people face most commonly, and we also asked about the strategies that they would suggest to the Ugandan Ministry of Health to reduce these burdens. Then, after that, we qualitatively coded these items, and we identified 8 unique barriers and 10 unique strategies. From there, we actually held a workshop, as you could see on the right side of the screen, where we were disseminating our original findings and analysis, and we held this workshop at Kampala at the Mulago Hospital Guest Hotel just to get original feedback, because generally in the Delphi methodology, you conduct feedback reports between each round where anonymously people can see what each respondent had stated, or overall as a group, what barriers and strategies had been provided and how they were ranked. So then round 2, after they saw their group feedback, they then ranked these unique barriers and strategies by impact and actionability for barriers and for importance and feasibility for strategies. After more group feedback into then round 3, when they re-ranked again, we were then able to identify consensus, and consensus is identified if a large amount of participants stated that impact and importance was above or equal to 5. And again, this is out of a Likert scale of 6 where they were rating things. And a median actionability or feasibility of greater than or equal to 4.5. So no, a really excellent thing about the Delphi survey and the Delphi model is it doesn't pressure people into agreement. It's just a very open space, or it creates an open space for convergence and opinions and ideas. So this was our final data. Now, not all of the barriers or strategies that we had identified were listed on this slide, but these were the top 3 just to save a little bit of space and a little bit of time. So these were the highest ranked items that we had. So for barriers, people agreed that there was insufficient training for healthcare workers. They really weren't able to recognize sickle cell disease treatments, and they really didn't understand the management of how to treat people with sickle cell disease. Then they flagged low community awareness as a top barrier. And then after that, it was the limited availability and the frequent stockouts of hydroxyurea, which, as we heard from our previous teammates, how important that medication is. For the top strategies, we wanted to expand the diagnostic capacity for sickle cell disease. We wanted to ensure universal access to hydroxyurea, and we wanted to establish free universal newborn screening, plus linkage to follow-up care, which is something that even when we do have newborn screening, it is very difficult to give people what's the next step. What are they doing after that? But as we already heard, again, from our lovely participants and from Dr. Manube and all of the other classmates who have stood up here, a lot of this is being worked on. So we are making quite a few improvements. Maybe we didn't need to do the survey after all. For our next step, what are we doing after this? So for our team, we are going to start working on policy briefs. So I know Dr. Stewart had mentioned we will be working with the Center for Advancing Policy Engagement, CAPE. They will be helping us take our data, take our evidence, and we are going to create targeted policy briefs that we can submit to the Ministry of Health. While we are still going through our findings and evidence, we need a coalition together to actually make these interventions happen. So we're going to be holding more stakeholder workshops, working with policy members, working with anyone interested, working with advocacy groups, hopefully so we can gather the team that will make our suggestions implementable. Finally, we then want to have our 10-point action plan. So after we have our expert identified priorities, and after we have data analysis, and after we work with CAPE, and after we work with all these stakeholders and we create the workshops and we get feedback, we then can create an actual plan to give to the Ministry of Health that talks about the implementable and feasible interventions that we have developed. And last but not least, we do want to work on some health system tracking. We will be coming up with key indicators so over time we can track if change is being made and if progress is being made. So all of this is extremely important because it really shows that what we are learning and the work that all of us students are doing at the local level can shape policy on a national level. And that is what makes the collaboration with Duke and UNC and Kalangala Health Center IV so important. So thank you for listening to my part of the presentation. And I know up next will be Nicole, and she'll talk about some data analytics.
Great. So next we're going to have a presentation about how we have been collecting all of our data, which has been a 7-year long process, but now we're finally to a point where we're doing electronic databases. And the student team is pushing us also into AI as well. So we're going to hear from Nicole. I'm also going to hand over to Samuel. Nicole is online and Samuel's here in the room. Nicole, can you hear us?
Yes. Thank you. Thank you, Dr. Stewart. So yes, I'll be talking about the data and the starting of creation of our dashboards here. And then Samuel will discuss the creation of the live dashboard. Next slide, please. All right, so to start off, our main goal here with creating the dashboards is to better understand patient outcomes and the barriers the patients are facing in both accessing care and in continuing their treatment. So to do this, we first built a data set that combines both clinical records as well as patient survey responses and interview responses that were collected this past summer, July of 2025. To have a data set with both the clinical records and the survey responses, we wanted to do this so that we would be able to capture not just the clinical outcomes, but also the patient's lived experiences. So from this data set that we created over the past couple months, we have created 2 static dashboards as well as the live dashboard in order to visualize patterns and trends in care and care delivery in the patient population, but also to be able to clearly communicate the patient story and where more support is needed. Next slide. Okay, so this is the first of the 2 static dashboards that we created. And so this first dashboard is showing the demographics of the patient population and what it takes to reach care. So the chart that I wanted to highlight from this dashboard specifically is the patient distribution map. So as you can see, the patients are traveling from a wide variety of different islands, and that there is also a wide variation in travel time depending on the island that the patients reside in. So patients from nearby islands may have an average round trip travel time of about 1 to 3 hours, while others are traveling up to 8 to 10 hours for care in those islands that are more in the distance there. And so this map here is a great visual just so you can see kind of the spread of the patients and where they're residing, but it also is showing the geographic barriers when it comes to accessing care and the time and the effort required to physically reach the clinic for some patients. Next slide. So this next dashboard is looking at clinical outcome trends as well as the quality of life of the patients. And the chart that I wanted to highlight from this dashboard is the pain interference severity chart. And so this data was taken from the patient survey responses, and it is reflecting how pain crises are impact the patient's ability to carry out their daily activities and to have a sort of independence with their life. So the categories here, severe is categorized as requiring constant care and support from family and friends during pain crises, and mild requiring some assistance from family and friends, but still being able to have a little bit of independence. So as you can see, a large percentage of the patients reported severe interference with daily life due to their pain crises. And overall, this is showing the day-to-day impact the patients are facing beyond what we can measure clinically, and can point to areas where support is needed for the patients as they navigate treatment and their pain crises. So with that, I'll pass it over to Samuel to talk about the live dashboard. Next slide.
Yeah, so I'm going to be talking about some internal tool that we've been building that basically helps the whole team to manage the data, and also a dashboard to show people like what the current data of the clinic is and how we can manage these expenses that we have, because most of our funding comes from private donors. So we want to show the people what we're doing and be able to like have a centralized place for the whole team to manage data and to fundraise for these funds. So can you play the video? So I'm going to show some of these things that we can do in this private tool. So we have a login for each team member to have their own access to their data. And something we can do is to look up the specific information for a patient, which can be really helpful in a clinic to pull up just the history of that patient and look at the data, see like their past vital signs. We can see like measures of blood pressure, heart rate, or even some other growth metrics like height, weight, BMI trends. And of course, we can also input some data that people in the clinic can be doing with the patients. They are going to be able to write when they're in front of the patient, they can just take these measures and put them directly into our database. And this is going to be updated with this other dashboard that we're going to show after. This clinical dashboard has an average of the whole clinic and all the patients that come to the clinic. And here, this is going to be updated every day with the information that is being currently entered. And we can also give access to the people in the clinic to change the data if there's any error, to correct mistakes. This is all connected. All it's going to be connected to the current data. And this is all also going to be shown in a public dashboard that we're going to show now, that is telling the story of the clinic. It's given an introduction of what sickle cell is and what the clinic is doing. We are going to have this interactive map that Nicole showed before that shows the distances to the clinics, and it tells a story of each of the patients that we have, but in something that is being updated every day. It also has these pictures of the fun moments that are so important to us. And we're going to be able to have all this data about our collaborators, all the people that have been working in this. And this is going to be a great tool for everyone in the team to have everything connected. We also have our social media and everything. And this button for donations that can allow people to just send any donation they want to our team. So yeah, thank you so much.
That is truly student-led. The innovation in the data is something that has come entirely from the student team. All right, we're going to move very quickly to the newest member of the team, Dr. Caleb Sega, who's going to talk about a really exciting opportunity for us to collaborate outside of our Duke UNC Kalangala network and include some Penn Plus colleagues.
So I'll be talking about delivering care where it's needed most, decentralizing sickle cell disease care, and the Pain Plus collaboration. So you've heard the word decentralization repeatedly throughout this presentation. So what does it mean anyways? So decentralization is shifting healthcare services from large central hospitals to local and smaller facilities so patients can access care around where they live. So Kalangala has been doing this for the past many years, and it is a level 4 facility, but it's delivering complex sickle cell disease care. For example, as you've heard, we deliver hydroxyurea to patients, and there is longitudinal follow-up of patients. And this model was born out of necessity, and it was an iterative process, and it was born due to geographic and access constraints. So it presents a real-world functioning example of decentralization, and we strongly believe with targeted support, it has the capacity to function at the level 5. And we're really excited for this because the evidence generated from this project will be an advocacy so that local health governing bodies recognize the work that has been done so far. So this brings me to the next exciting collaboration we'll be having with the Pain Plus initiative. They actually saw what we've been doing and this gained traction, and they reached out for collaboration. So what is the Pain Plus? The Pain Plus is a global strategy to decentralize severe non-communicable disease care. It stands for Package of Essential Non-Communicable Disease Interventions, and it's led by Harvard Medical School and Partners in Health. So they've already implemented their version in 2 clinics in Atatur and Nakaseke, plus Ssese, which is operated by MSA for the doctors who are board. So what we'll be doing is generate evidence, document the decentralization process objectively. What were the buyers? What were the facilitators? And we'll be doing this from the patient, the provider, and the community stakeholder perspectives, and take that evidence and really make an argument for the clinic to be level 5 health center. And the other overarching goal of this project is advocating for decentralization to be adopted by the national governing bodies, as well as give other health centers in resource-limited setups a model. And I hope this will inform other decentralization efforts in low and middle income countries. We're very excited for this. This is the exciting future. And yeah, at the end of this, we believe Kalangala has the chance to be recognized for the work it's done.
So maybe next year we'll hear from Dr. Sega presenting his thesis work on this. All right, we are almost at time. We have one very last, maybe 2 minutes. We have the founding director and my long-term collaborator and dear friend, Musao Joel Kibonyuwake, who's just going to talk about the future of the clinic. Musao Joel, can you hear us?
Yes, please, I can.
Great. Could you wrap us up with 2 minutes about the future?
Thank you very much, Professor Stewart. In these few minutes, I would like to bring up something called bridging the global standards and island realities. The respect is made to all the funding bodies and the rest of the players, both local and international, with a special reference made to the factors influencing the patient's outcome, especially in Kalangala. Here in Kalangala, following all that you have had, locally, we decided to do what we call a sickle cell clinic construction. And this one, we named it a brick by brick challenge. This one locally, we look at everyone who is in our community can contribute as little as 1,000 shillings, and it is led by a nurse who is a volunteer at the clinic called Zakaria Semukasa. Next slide, please. Okay, we are thinking that by the end of 5 years, working hand in hand with the local organizations, that is the Rotary Club of Kalangala and Ssese Islands, and Kunihira Sickle Cells Organization, we are intending to raise a total of $200,000 US. That will be able to help us to erect a block, which is a single story, that is a 1-floor block, as you can see in the diagram below, which is going to be our sickle cell center, whereby we can give quality sickle cell care, and where all those that have been presented up will be housed. Next slide, please. Summing it up, we are doing this locally, and it is within our community. As you can see in this slide, we are being helped by the Rotary Club of Kalangala Ssese Islands, where all this year I have been sitting as the Rotary President, and we are also sitting in with an organization called the Kumihira Sickle Cell Organization, which is an organization that was created from the patients who are from within our own clinic. And on that, we in the community, we are having a dinner which will help us to increase enough money, especially to raise for our foundation. And we hope to do a starting off of our clinic in June 2025. So we think by the end of 5 years, we will have a fully fledged sickle cell clinic, and which will help us to prepare for our patients to be able to compete and go for generally for things like gene therapy and bone marrow transplant. Thank you very much for listening to me. Have a good day.
Thanks, Joel. We really wanted to highlight that this is a community-based local effort, and it's quite a remarkable achievement for Musao Joel to really bring his whole community to support him in this effort. I know we're at time, so I'll just hold off on these lessons.